Hey everyone, welcome to a little presentation specific to personality disorders. So, just a little bit about why I think it's important that we take a little sort of sidetrack to talk about personality disorders. So, even though personality disorders don't usually lead to hospitalization themselves, the manifestations of some of the behaviors and concurrent mental health illnesses could lead to an inpatient stay in a mental health unit. However, you will come across quite a few patients in your practice as a nurse that are on a medical surgical floor that also have a personality disorder. So you say, well, so what? Well, what's important when you are assessing patients is understanding the difference between normal and abnormal. That's what we do. So, what is normal for a person without a personality disorder is not the same as what's normal for a person with a personality disorder. It's going to change the way that you perceive them, how they perceive you, how they act, how they behave, your assessment findings. And if you don't understand what their baseline is, you're not going to be able to tell if something is abnormal. So, since it's something that I know I come across quite a bit as a nurse on the floor, I know you will as well. I really wanted to make sure that you understand how some of these personality disorders manifest so that you can identify it and treat the patient in a way that gives them the best chance for a positive outcome. Cluster A. So you're going to see manifestations physically and behaviorally that are odd, eccentric, and socially awkward. So first let's look at the origins of the word paranoid. It's derived from the Greek paranoia, meaning madness. It's formed from para, meaning abnormal or defective, and nous, meaning mind. So that helps you kind of understand why it's called what it's called. So, when you're looking at the characteristics and the definition, think about what this means in the clinical setting. They're going to be very hard to get to trust you and develop that therapeutic relationship. They're they have this persistent belief that everybody's got malicious intent. So, when you're educating them or even when you're doing your assessment, there's going to be thoughts that you have intent to either harm or damage them in some way. They're preoccupied with these doubts. They are reluctant to confide. Are afraid that you'll use the information against them. So think about that in terms of collecting a health history or trying to get them to tell you about their symptoms. They see hidden and threatening meaning in innocent conversations. So you have to be very careful with the communication techniques that you use with these patients so that they're less likely to think that what you said has some kind of ulterior meaning or motive. They'll hold grudges and perceive things as attacks to their character. So perhaps you've done something inadvertently to offend them. They may be that patient that needs switched to another nurse because these grudges are deeply held and they're not going to just pretend that it didn't happen because they really believe they've been wronged in some way. So let's talk about schizoid personality disorder. First, why is it called schizoid personality disorder? What does that even mean? So the term was coined in 1908 to describe a tendency to focus on one's inner life and away from the outside world. Schizo or schitz comes from the Greek word schiza, meaning split or splintered, and the suffix oid means resembling or like. So they live in this world where part of a patient or a part of a person's personality is directed towards the outside world and social relationships and connections and emotions, and they split away from that and turn inwards. They withdraw. They have a limited ability to express emotions. They don't desire relationships or sexual pleasure. Um, they choose to be alone. They don't have close friends. They appear indifferent, both to criticism and praise, and they come off as cold, detached, and flat. So, from a clinical standpoint, if you were assessing a patient that you didn't know had schizoid personality disorder and you saw these things: a cold, detached, flat affect, complete indifference. Right off the bat, those are abnormal findings. Bring into the picture that they have schizoid personality disorders, kind of help you understand what their baseline is. Also, if they appear indifferent to education or their treatment regimen and things like that, it's almost like they don't see the importance in it. Not necessarily that they don't internally, but externally it's going to come across like that. So what about discharge aftercare? Are they going to take it seriously, take care of themselves? Are they close enough to anybody if they need help after discharge? So those are some things to think about. So what about schizotypal personality disorder? This word was coined to describe dynamics and classification of disordered behavior. In the past, it was also called schizoataxia. So think about that. Schizo, split, splintered. Ataxia, impaired, discoordination, damaged. Um, so those are some of the reasons why it's called what it's called. So people with this personality disorder are intensely uneasy with intimate relationships. There's also a characteristic of this personality disorder that they display in their appearance, in their speech, in their thought process, odd and eccentric characteristics. So they are going to appear and sound odd and eccentric. That right there, when you're doing an assessment, you're going to think that that's abnormal. It is abnormal, but for somebody with this personality disorder, it may be their baseline. So, some key points for this: the ideas of reference, false belief that coincidental events are related to them, when they're thinking magically that they can influence a situation or an event by doing something that has nothing to do with it, and the body illusions where the perception of their body isn't what it actually is. If you came across those findings and did not realize this patient had already been diagnosed with this personality disorder, of course you're going to be like, wow, this is a big deal. And it is. I'm not saying that it's not something that you don't discuss with the provider and things like that, but it gives you a frame of reference. So all of these things considered, when you're conversing with somebody with this disorder and they are saying things in a bizarre manner, just remember, it doesn't necessarily mean that they don't understand you. It doesn't mean that they don't get it. It just may be their way of expressing themselves. They can become paranoid and they have kind of a blunted or constricted affect. So, again, with the therapeutic communication, make sure you're using it appropriately and taking those things into consideration. With the lack of close friends and excessive social anxiety, there's also the discharge planning barriers. What if they need help after discharge? Are they going to be able to follow through? Do they have anybody to help them? So those are some things to take into consideration. So look at the difference in the description between cluster A and cluster B personality disorders, and it helps you understand why they need to be clustered the way that they are. So cluster B, they're dramatic, overly emotional, unpredictable, and that can be thinking or behavior. And it includes antisocial, narcissistic, histrionic, and borderline personality disorders. Well, there definitely isn't a need to look into why this is called antisocial. It speaks for itself. Um, so these people have a tendency to ignore and infringe on the rights of others, and a defining characteristic is also that this personality disorder appears by the age of 15. So that can kind of help delineate it from other things. They don't conform to social norms, deceitful, impulsive, irritable, reckless, and irresponsible. What does that mean clinically? First of all, they may purposely or overtly push back against advice, discussions, even medication. Uh, when they're talking about ignoring and infringing on the other rights, these also might be the type of patients that purposely and overtly push boundaries in terms of their behavior and their defiance. They're deceitful, think about that in terms of health history, impulsive, safety, reckless, safety, irritability. That has to do with interpersonal communication. How easy is it to approach somebody with important information or even to pass medication when they're being exceedingly irritable? So it's like almost like they're pushing you away. So you have to keep that in mind and make sure that you're still taking good care of them. And then irresponsibility. How are they going to do after discharge? Um, are they even going to follow through with what has been prescribed? Some points to ponder. Next, we have borderline and histrionic. And I have these together, sort of a side by side comparison, because in my experience, they can get confused until you kind of know more of the specific characteristics. So, borderline is instability across the board, relationships, perception of self, emotions, and they're very impulsive. They are frantic to avoid abandonment. Their self image is very unstable. So, what that means is they can go from a great sense of self or even a bigger sense of self than is within normal limits down to the lowest low, where they have a very, very low self esteem. They have the impulse to self injure. Um, their impulsivity is usually self damaging. They have suicidal behavior, ideations, they feel empty, intense anger. They have a tendency to severely dissociate, and when they're under stress, they do become paranoid. And when you look at histrionic, this is a pattern of attention seeking. They display intense emotionality, but it's in the context a lot of times of that attention seeking. They have to be the center of attention. Their emotions, while intense, are shallow. And sometimes the difference between borderline and histrionic, even though they can be highly emotional, is that borderline does come across as more genuine and histrionic is exaggerated and theatrical. They use their physical appearance to gain attention. They engage in impressionistic speech, which means it's vague, it's general, it lacks detail. It can be them talking in circles or excessively about something that they don't really understand, either to get attention or to get people to engage with them. It can even maybe be saying what they think would interest or what somebody else wants to hear. So let's look at some key differences between the two. With the borderline, you have the intense anger, the suicidal behavior, and the self injury that you don't necessarily see with histrionic. So, clinically, you need to be ready and understand the impulsivity. So, we need safety, safety, safety. Also, the instability in their emotions and self perception. That's going to impact the way that they interpret the information that you're giving them and the way that they react. And also assessment findings. That's when they're unstable like that from one assessment to another. For histrionic, also remember that they're highly suggestible. So if somebody tells them something or they hear something, whether it's true or not, they're quite likely to believe it more so than other people. They might be on the call light a lot. Actually, both personality types, with the attention seeking or the fear of abandonment. Remember the expressionistic speech where they're talking in circles or they're talking in very vague terms just to kind of keep your attention. And then also with both types of personality disorders, these these overarching needs with the histrionic for attention, the borderline with the fear of abandonment. How is this going to impact them at discharge? Narcissistic. So either we've said it ourselves or we've heard other people say, oh, my ex-boyfriend, ex-girlfriend, somebody is narcissistic. There's a difference. People can have narcissistic tendencies without having narcissistic personality disorder. So they have an exaggerated self-importance, and that's either in their head or in their behavior. They need attention and they lack empathy. Uh, this inflated sense of importance and preoccupation with fantasies of power and brilliance and success and money kind of overtakes them. They believe they're special, but not only that, they think that only other special people can help them. They'll exploit people to get what the other people to get what they want. They don't have any empathy, really. very little, if any. And even though they think that they just have everything and they're so grand, they're envious, but they're also arrogant. So, care considerations. Are they going to take what you have to say seriously? Or are they going to think that they know it? Are they going to think that what they think is going on is better than what you think is going on? Is their treatment better? Are you even qualified to be giving them advice? Those sorts of things. Also, be careful of manipulation when they're trying to exploit people to get what they want. That doesn't stop at, their family and friends. That can definitely translate into the clinical setting. Also, after discharge, are they going to follow any of the prescribed regimen? Finally, cluster C, anxious or fearful thinking or behavior. This is avoidant, dependent, and obsessive compulsive. And again, you're going to see some defining characteristics that are very different from cluster A and cluster B. Avoidant, again, no need to explain the meaning or origin of that word. The avoidant is exactly what it sounds like. They avoid interaction, they consistently feel incompetent, and they're also very highly reactive to criticism. So, things to consider when taking care of a patient with avoidant personality disorder. They are constantly feeling inadequate, unprepared, socially awkward. Not that they necessarily display awkwardness, but they believe that they are inept. So, um, are they going to even feel like or convey that they can understand the instructions? Um, are they are they going to interact with you in any meaningful way? Are you going to get signs that there is understanding of the education? Also, when you're talking to a patient with this personality disorder, be careful how you choose your words. Fall back on your therapeutic communication because they're so highly reactive of criticism that once they feel they've been criticized, they'll ruminate about it. They will have inhibited affect and inhibited moods, but it's not that they are unable to display those emotions and moods. It's just that they hold that back. So that can impact your assessment findings as well. Dependent. What you're going to see with people with dependent personality disorder is they are likely going to agree with everything you say. Um, they they need somebody else to take charge. It's very hard to get people with dependent personality disorder to be meaningfully engaged in their care planning because they always want to defer to somebody else. Also have a real anxiety of being alone, and they're very preoccupied with this fear of being alone. So this is somebody that might call repeatedly for help and not really have any needs because of that intense fear, feel hopeless when they're alone. So we need to make sure that they're safe. So from a safety perspective, there's not just that, but they urgently seek relationships and connections. They can put themselves in situations to be abused or taken advantage of physically, emotionally, sexually, because of that intense need to be with somebody else. So, for discharge planning for somebody with this type of personality disorder, it's going to be very hard to get them to initiate anything, and it's going to be very difficult to get them to express whether they have any concerns or if there's something maybe that they disagree with. It's also going to be very difficult if they don't have a lot of support at home because they're looking for somebody else to take care of things. Obsessive compulsive. The biggest thing here is not to confuse obsessive compulsive disorder, the mental illness, with obsessive compulsive personality disorder. There are some differences, big differences. With obsessive compulsive disorder, the mental illness, there's recurrent, intrusive, unwanted thoughts and uncontrollable repetitive behavior. People with OCD feel distress and anxiety when they're experiencing symptoms, and they fluctuate. With obsessive compulsive personality disorder, the person always wants to be in control. They include strict orderliness, perfectionism to the exclusion of effectiveness. Um, they're overly involved with work and productivity, and that keeps them from having outside relationships and leisurely activities. And their obsession with orderliness and perfection keeps them or stops any spontaneity. So those are some differences between the two. So clinical considerations. If people are preoccupied with details, rules, lists, organizations, schedules, they may have lots and lots and lots of questions. They write things down excessively. They may try to make sense of abstract concepts because, in medicine, a lot of times it's inexact. So that could really be a problem for them. Um, they may experience burnout from their excessive devotion to work and productivity. Their over conscientiousness and scrupulous and inflexible with morality, ethics, or value. But note, it's not based on religious or cultural considerations. It's part of the personality disorder, so you have to separate the two. But with being over conscientious like that, if there is something that is prescribed or they're educated about something that goes against that strict set of guidelines that they have for themselves as far as ethics, morals, and values, could run into trouble there. And they are reluctant to delegate and spend money, and they're very rigid and stubborn. So what does that mean for what if they need help after discharge? What if they are just completely against like a doctor dictating any of their care at all, or a nurse giving them any education? But if they need taken care of, that's going to cause them problems. If they're not open to getting advice, that's going to cause them problems. And if they're so rigid and stubborn in their own thoughts, beliefs, feelings, and behaviors, are they going to even be open to health maintenance and health promotion type behaviors? Some final thoughts. Again, I just want to reiterate that not every personality disorder mentioned, the people don't have every single one of these characteristics. Also, the clinical considerations we talked about, that's not an all-inclusive list. It's just they were points to kind of get you thinking about how these characteristics and definitions can apply in real life. Also, like it says in your text, and we touch on it in the synopsis, there are no medications for personality disorders. Medication used in people with personality disorders are meant to mitigate the manifestations, like the anxiety or the insomnia or things of that nature. Antidepressants for the suicidal behaviors or depression that goes along with some of them. Also, psychotherapy is key with personality disorders. Cognitive behavioral, dialectal behavioral, different types of psychotherapy, psychoanalytical and psychodynamic therapies. So, in conjunction possibly with medication. Sometimes, if you can treat the cause of the personality disorder, or one of them, because it's very complex, but let me give you an example. If there's unresolved trauma that has shaped this personality disorder, sometimes the therapies can get to the root of those unresolved traumas, feelings, or fears, and it can help the patient overall. Thanks so much.